This was how this 3-year-old child presented to me 3 years back, 2 months after she developed Stevens-Johnson syndrome, extremely photophobic, requiring examination under anesthesia, and this was the status of both her eyes. And this is how she is 2 months back. Okay? कौन से आंख से दिखता है? मैं दिख रही हूँ? अभी? अभी? Same? Same? So this is 3 years after we first saw her. What was done? Well, we shall take a look at that as we go through the talk. This was another patient of Stevens-Johnson syndrome, 55-year-old male who's undergone mucous membrane grafting for lid margin keratinization with fornix reconstruction, phacoemulsification, and uses scleral contact lenses in both his eyes. This is in 2026. How far back does his presentation go back to? Well, these are pictures from 2014. Was it only that long back? This is when we published about this particular patient and the procedure, and that was in 2002, which is almost 24 years of follow-up. So I think the biggest takeaway in ocular surface diseases is that follow-up and compliance are basically non-negotiable. Both of these were patients of Stevens-Johnson syndrome, a landmark paper that was published under the lead authorship of Professor James Chodosh that we were a part of, which clearly highlights the windows of opportunity in Stevens-Johnson syndrome, the mandatory roles of us as cornea and ocular surface specialists. Stevens-Johnson syndrome is one of the most common cicatricial conjunctival disorders that we come across, and there are several other conditions that I shall enlist which one should keep in mind when we see patients with cicatrization. In ocular surface disorders, well, one can lose in two currencies. A missed window of opportunity where you lose time, which creates advanced disease and it advances your ending line, and a mis-execution within a window of opportunity where you might end up losing anatomy and function. It creates the hidden burden of revision disease and it reboots your start line. And therefore, it's essential in OSDs that you don't just act early, but you act precisely. In OSDs, one can also lose in missed diagnosis, also misdiagnosis, which is why one needs to take your time and zero in correctly on the diagnosis, which is basically what we've been hearing to in all the talks today morning. And what I'm here to share with you today are the lessons that I have learned over time, the ocular surface in the real world. And let me thank the organizers of SACON, Dr. Ashat, Dr. Harshali. This is the second time that I'm coming here and it almost feels like homecoming. So thank you very much. Why ocular surface disorders are different? Well, these are chronic conditions which are multifactorial, dynamic, emotionally disabling with a significant symptom sign discordance. And whatever said and done, OSD is a recent and evolving field. It rarely reads the textbook. It has significant variability, overlap syndromes, neurobiology, and systemic interplay. Guidelines in OSDs help us begin, but it is experience that helps us individualize. I spoke about cicatricial conjunctival disorders, but let me begin with this relatively simple aqueous tear deficiency that we see in patients related to Sjogren's disease. This was a patient of rheumatoid arthritis for the last 10 years, not on any medication, but the eye looks largely quiet. She's asymptomatic, has a vision of 6/6, has had her cataract surgery done. But when you stain the eye, you can see there's significant amount of corneal epitheliopathy. Well, is there really a cause for concern in these eyes? If she's quiet and has good vision, do we really need to bother? Well, this is how she presented in the other eye with a corneal ulcer and infection, which is what these patients are always at a risk for if you do not treat the underlying rheumatoid arthritis and do not stabilize the ocular surface, which ultimately required significant treatment. And what we had to do for her was a punctal cautery in both the eyes, and you can see a significant resolution in the corneal epitheliopathy. When you look at these patients with Sjogren's disease or rheumatoid arthritis, what really strikes, and especially something that we've been trying to communicate over the last couple of decades, that this is not usually associated with cicatrization. And why do I say that? Because this was a patient who had been diagnosed as rheumatoid arthritis by the ophthalmologist, and no other signs of any underlying rheumatological disease, but the rheumatologist was treating the patient as RA based on the dryness that the patient had for almost 6 years with absolutely no resolution. In fact, there was a progression in the condition. And then she was referred across to me, where the first feature that struck was that she had cicatrization. A conjunctival biopsy was done, and this turned out to be an ocular cicatricial pemphigoid, which, when subsequently treated appropriately, showed a significant improvement in her ocular signs and symptoms and has been consistently stable for the last 4 years now. These are subtle signs of cicatrization that we should not miss as clinicians, and this is classically another patient of OCP that was proven with biopsy. This, in fact, was a patient who had presented, I think, almost 13 years back to the ophthalmologist, and just based on the fact that she had recurrent oral and genital ulcerations with redness in the eye, had been diagnosed as Behçet's disease, was on multiple immunosuppression, and when she came to me around 4 months back, this is how she presented. The first thing that I noticed was the fact that there was inferior pharyngeal shortening and cicatricial changes, which made me pretty sure that this was not Behçet's that we were dealing with, because that does not present with cicatrization. There was no evidence or signs of uveitis either anterior or posterior in her. That was the other eye of the same patient. And this was a patient where we again diagnosed had OCP with probably a secondary viral infection, started her on acyclovir, subsequently systemic steroids and immunosuppression, and ultimately this is how she looks now with complete resolution of the inflammation. However, she does require regular follow-up. So what I would like to highlight here is that when you're dealing with a patient of dry eye without cicatrization, you need to go down the road of Sjogren's disease when you're evaluating such patients. But this first sign of cicatrization that you see should take you down another path, understanding what the causes for cicatrization in these patients are, because they're completely different in terms of their diagnosis, in terms of their management. And what we need to remember is that in cicatrization, in Sjogren's disease, at the cost of being repetitive, cicatrization is extremely rare. The pitfalls that are associated with diagnosis is one, of course, a missed diagnosis, as we saw in the other patients, where it leads to a delayed intervention. And on the other hand, you can sometimes end up with a misdiagnosis, where you end up unnecessarily intervening and treating the patient. Like this young girl, 20-year-old female, was treated with high-dose immunosuppression, including cyclophosphamide. She had cicatricial changes, which was diagnosed as OCP. She presented to us with a microperforation, and when we revisited her history, we realized that her problems had begun when the entire family was affected with an episode of adenoviral conjunctivitis. And this was actually a patient of post-conjunctivitis, cicatrization-related dry eye, and not OCP. And this was a patient that had been started on cyclophosphamide for the same. Just a punctal cautery in this patient, significant improvement in her signs and symptoms, and she continues to be symptom-free till almost last week when she came back for a follow-up, almost 7 years since I first saw her. So this was a patient that was misdiagnosed as OCP or MMP, and the key takeaway here is cicatricial changes specifically point towards certain disease conditions, which I have enlisted here. Well, we do have immune diseases where SJS and OCP top the list. It could be infective like trachoma or adenoviral, chemical injuries, masquerade such as a pagetoid spread of sebaceous gland or squamous cell carcinoma, and drug-induced cicatricial conjunctivitis. Those are the classical conditions that lead to cicatrization, and inflammation is the hallmark of cicatricial disorders. And when we compare what leads to inflammation in OCP versus SJS, well, OCP is largely immune mediated and requires systemic immunomodulation in comparison to Stevens-Johnson syndrome, which is largely mechanically induced inflammation in the eye, where the utmost importance is to stabilize the ocular surface. This is a patient that has significant lid margin keratinization, leading to corneal changes, where all that we did was a mucous membrane grafting for the lid margin keratinization, and you can see the significant improvement in the surface. Long-term outcomes of these patients are now well established, which is basically what has led us to defining the windows of opportunity in patients with Stevens-Johnson syndrome, both the role of punctal cautery for dry eye and mucous membrane grafting for lid margin keratinization. Equally, you can miss an opportunity of window in SJS. As in this patient, where the puncta were open, it is usually assumed that in cicatricial patients the puncta gets blocked, whereas you will be surprised to see that when you syringe the NLD, most of these patients have an open punctum, and all that this patient required was a punctal cautery. You can see the significant improvement in the surface, and if this would have been performed much earlier, we could probably have reduced the impact of a dry surface on the cornea and the limbus. The effect of punctal cautery within 3 hours, you can see the significant amount of improvement in the surface. Another patient of SJS, where all that we have done is a punctal cautery, and you can see how much the surface and the cornea actually clears. Another lady, one-eyed, who presented like this with significant lid margin keratinization and open punctum. This is post punctal cautery, this is post mucous membrane grafting for lid margin keratinization. Initiated this patient on systemic immunosuppression, and then an alloslet that was done with her vision improving to 612 with scleral contact lenses. We do have keratoprosthesis as an option for these patients, but the idea is to try and see how much you could postpone the need for K-Pro in these patients, how much you could actually treat them by surface stabilization procedures. However, one needs to be equally vigilant that you might end up having missteps or missed execution in a window of opportunity. A very bulky mucosal graft like this is not something that we like to see in these patients of Stevens-Johnson syndrome. This is how it should look, absolutely flush and flat, because a bulky graft causes more harm than good. This was a young boy who presented with large mucosal grafts, and it takes a lot of time to work on these patients, revise their mucosal grafts, but you need to do it, because if you do not do it, then they do end up having bigger problems. Another patient that presented to us with a not so well done mucous membrane grafting, which required multiple revision surgeries so that we could make it cosmetically acceptable as well as less harmful to the ocular surface. Our work on Stevens-Johnson syndrome and ocular surface disorders, well, we did publish the role of comprehensive care in these patients of SJS, and contributed to the paradigm shift in the management of patients with SJS, which is now considered today as standard of care. Just the lessons learned through some of these cases. I took up just cicatricial disorders because this is one area where sometimes we do miss certain subtle clinical signs. Sjogren's disease is not associated with cicatrization. Cicatricial changes point towards specific diseases. History taking still remains gold standard, and clinical examination holds the key. Tools are useful, but they are only of adjunct value, and the perils of both missed as well as misdiagnosis and a missed execution and misexecution are some of the examples that I tried to highlight. This is the communication or documentation that we follow in all our patients of ocular surface disorders that helps us document every little aspect of changes that we see on the ocular surface, and also helps us communicate with our colleagues. Well, ocular surface disorders go way beyond what I have shown here today, and it's important that we understand the pathophysiology. There are several management options, and each disease and each condition warrants customized treatment, which goes beyond the scope of this particular talk. But the biggest takeaway and the biggest lesson, if I might have learned in the last couple of decades, is the need to build an ecosystem for ocular surface disorders and the capability to do so through the various roles and positions that I have held, and that is what led to the initiation of an Institute of Excellence for Cornea, Ocular Surface and Dry Eye called as CODE Eye Care in Chennai, where we specifically get patients referred for ocular surface disorders, not just from different parts of the country, but from different parts of the world. Keratoprosthesis forms a very, very important aspect of our management armamentarium, with some of these patients maintaining a 6/6 vision over 2 decades, where we continue to work on the various aspects of keratoprosthesis, the different types of keratoprosthesis, helping us manage these otherwise end-stage OSDs, taking us where we today stand as the largest volumes of K-Pros being performed globally actively, and being able to offer all aspects of management for ocular surface diseases under one roof. As a board of director of the International TFOS and having contributed to DUCE 3 diagnostic methodology, it helps us to draft guidelines for the management of dry eye and ocular surface disorders. We do offer training programs for those interested in cornea and ocular surface fellowships. I haven't forgotten. I will finish with that young child that I started off with. This is what we basically did for her, an alloslet to both the eyes after the excision of the symblepharon with mucous membrane grafting. And this is how she looks today, 4 years after her presentation. She's under systemic immunosuppressives, under the care of a nephrologist. So it's an integrated care that one needs to offer to these patients. And that's how she comes, always running into my clinic. And I will just end by saying that every scar in the conjunctiva and in the ocular surface tells us a story, and as clinicians, our responsibility is to ensure that it is a story of resilience and recovery. Thank you.